All right. Good afternoon, everyone. It's a real pleasure to be here. It really is an excellent event, and I'm happy to participate. I know everyone is very postprandial. I will try to keep you all awake. Remember, I'm a respirologist. I can catch the OSA in the crowd if there's hypersomnolence. I was tasked with a discussion about pulmonary toxicities with novel cancer therapies. I know that the focus this morning really was on immune-related adverse events with immunotherapies. Sorry, I'll start with my disclosure slide here. But in my portion of the talk, I want to go over not only risk factors, incidence, clinical radiologic patterns. So we're going to look at some radiology because it's so important to understand the sort of trajectory of lung toxicity and what happens with the clinical and the radiology presentations. And I'll hit on not only immunotherapy toxicities, but touch on TKI and a newer class of drugs, ADCs, very relevant right now for the pneumonitis world. Immunotherapy was so 5 years ago. Now we're into the ADCs, and we'll review the investigations and management guidelines for pneumonitis and some practical clinical implications. Okay, so first off, when we discuss drug-induced pulmonary toxicity, historically we think about chemotherapies that cause lung toxicity. This is not new. We've seen it with gemcitabine, bleomycin. Medical oncologists are used to seeing possible pneumonitis or lung toxicity. Now with precision oncology, novel classes of medication, of course, we're seeing that all of these anti-cancer treatments have diverse side effects. We're seeing a lot more and a lot sort of, different profiles of toxicities. With respect to pulmonary toxicities, it's not just pneumonitis, it's not just interstitial lung disease. You can think about bronchospasm, you think about pleural effusions, there could be other manifestations. My focus today is really related to pneumonitis, so more interstitial lung disease or parenchymal lung disease, and related specifically to TKIs, immunotherapy, and the antibody drug conjugates. So just a quick word about, what does it mean to have a pneumonitis, to develop pneumonitis? So it's really a broad spectrum of clinical presentations of inflammation of the lung parenchyma. There's inflammation, there's scarring, the interstitium thickens, and there are chronic changes that could lead to fibrosis. What are the causes of pneumonitis? So they can be broadly categorized into 4 main groups. So you have the idiopathic causes. These are the ones that we call, idiopathic pulmonary fibrosis or UIP type patterns. There are those that have genetic predispositions or genetic abnormalities. There are autoimmune conditions, and we have rheumatologists in the room, of course, who see scleroderma patients, rheumatoid arthritis patients who develop connective tissue disease-related ILD, and of course, exposures, right? So here we're talking about drug exposures or drug toxicity, but there are other exposures that can do this. We think of viral infections, occupational exposures. So these are the types of things that I see in my practice. And we'll remember that 1 in 3 cases of ILD or of pneumonitis may not have an identifiable cause. So we'll go over some of the risk factors. So pertaining specifically to sort of the world of medical oncology and the patients that we treat with chemotherapy drugs or targeted therapies, there are general risk factors which are common to all. So we think of pre-existing lung disease. So certainly someone who already has underlying interstitial lung disease, reduced lung function, will be more at risk. Poor performance status keeps coming back as a risk factor. Smoking history, older age, Japanese and African American ethnicity has been reported on several papers and case series, and male more than female sex. If we think about risk factors, those are general risk factors. Pertaining specifically to our oncology world, other additional risk factors certainly can include prior treatment to multiple chemotherapies. Why? Because they might have already been exposed and had some lung injury from previous therapies. A history of radiation treatments, radiation recall pneumonitis. This can predispose to drug-induced lung injury with re-exposure to new drugs. Squamous histology in lung cancer seems to be more at risk than adenocarcinomas, certainly with immunotherapies. Presence of lung metastases, because this is where sort of the antibodies, flock to, and prior drug-induced pneumonitis, and ongoing treatments with molecularly targeted agents or combinations, right? So the more you combine agents with a risk of interstitial lung disease, the more risk there is. We know from immunotherapy trials that specifically the top two, the bottom ones are sort of common, and we saw them on the previous slide, but combinations of PD-L1 and CTLA-4, and specifically EGFR TKIs that follow immunotherapy. There's even a more increased risk of pneumonitis in that instance. This is a publication from a pooled analysis of patients who developed pneumonitis with T-DXd. So this is the trastuzumab deruxtecan ADC. I'll get to it in more detail, but just to kind of highlight that even in this patient population, the risk factors repeat themselves. So we see the same type of groups who are at risk, the Japanese more than non-Japanese, lung comorbidities, poor ECOG status, and prior lung disease. So then we look at some risk factors that may increase the risk of morbidity and even mortality, because we know that pneumonitis happens more frequently than some of the toxicities we saw earlier this morning, say like myocarditis. Myocarditis carries a higher mortality, but the risk with pneumonitis, if not caught early and treated early, carries a high risk of mortality. So what are the things that are red flags in terms of risk for morbidity and mortality? Acute symptom onset, so rapid presentation. These are the cases that present with like an acute interstitial pneumonia pattern, an AIP. Hypoxemia, the need for, of course, mechanical ventilation or oxygenation. Pre-existing ILD, these patients are definitely more at risk of morbidity and mortality. Older age and non-small cell lung cancer by itself also carries more risk. I'll go over some of the clinical and radiologic presentations. So as a general rule, pneumonitis essentially is a radiographic finding at first, so it may be incidental, and it may be picked up really just on your routine, restaging CTs. So when it's asymptomatic, these are the ones we call grade 1, incidental finding on CT imaging. Otherwise, if a patient does become symptomatic because there is more evolving pneumonitis, then they'll present most often with dyspnea, cough, hypoxemia, fever. Those, I would say, are the most common symptoms. And again, they're very non-specific symptoms. Many other conditions can present with similar clinical scenario. We also have to bear in mind that if we're thinking about pneumonitis in a patient who's at risk or who has therapy that could put them at risk for pneumonitis, looking for concomitant adverse events may be a clue as well. So we think of patients with immunotherapy might have some respiratory symptoms, but also developed a diarrhea and symptoms of colitis at the same time. And that raises our level of suspicion as well. And rash, of course, is a common clinical presentation. So one thing to bear in mind, especially for those who are treating lung cancers, and of course any other tumor patients may present with symptoms that can have a broad range of other causes. Okay, so when we look at differential diagnosis for drug-induced ILD, we have to think about infectious causes. So opportunistic infections, these are patients who are very often on steroids for some other reason. Alveolar hemorrhage is a more rare complication. I would say that's more at the bottom of the list. Metastatic involvement of the lung, right? So patients with metastatic disease from another primary or lung cancer may be having any of those symptoms because of progression of disease. Heart failure, and certainly in someone who has prior history or some other cardiotoxic medication on board. Infections we talked about, aspiration, radiation-induced lung injury, and of course, pulmonary embolism as well is a common complication of cancer patients. So we have to consider that there may be other reasons why patients are presenting with these symptoms. Why is this important? Is because we need to rule in or rule out whether we think, and that's part of my job when I evaluate these patients for pneumonitis, whether it's drug-induced or not. And it has implications about continuing therapy, maintaining therapy, hold, rechallenge, et cetera. So we think about whether there are signs of progression of cancer in the lungs, so lymphangitic disease, there may be volume loss or collapse because of endobronchial disease. There may be a new presentation of pleural effusion causing that symptomatology. So radiology here will be very helpful in my differential diagnosis. Is there a pre-existing diagnosis of ILD? So this is something that is at times not picked up at baseline. So I would say that in patients with colon cancers, with breast cancers, the focus is not so much the lungs. They may get staging CTs, and there may be very minimal signs of interstitial lung disease that's already present at baseline prior to them initiating therapy. the mention of it in a radiology report may be very subtle. It's not something that a medical oncologist will necessarily pay close attention to. However, that person has the risk factor. Once they're exposed to drugs that may cause pneumonitis, then the complication happens. So these patients get referred to us for management, for investigation, but I can see that prior to initiation of therapy, there was already a risk there. By the same token, it may be as well that the pattern and the changes over time may be strictly related to that pre-existing illness and that there aren't necessarily indicators that this was a drug toxicity. And so that's part of the job with our investigation. Dyspnea, cough may be due to airways disease, unrecognized COPD that needs management as well, and it may not be a lung toxicity at all. For the radiographic findings, again, you may have an incidental finding, and we need to see what that radiologic timeline was, and is there another explanation for that finding, or is it truly something that is temporally related and causally related to the drug in question? A couple of slides or a quick word about imaging itself, because very often I have fellows, medical oncology fellows that come to my oncology clinic. So I wear two hats because I am a respirologist, but I also treat lung cancer and I have pulmonary oncology training. And so when I order my CT scans, and it's really just restaging CTs, if I need contrast to look at lymph nodes and whatnot, I'll order it. But by and large, I would say that a lot of medical oncology trainees will order CT chest, abdo-pelvis with contrast. and sometimes, of course, it's needed for restaging purposes, but I will make a point here to say that when we're looking for pneumonitis and you do your routine restaging CTs and something's picked up on that CT scan, that's enough to then make a diagnosis or at least refer for investigations and management. And the follow-up, let's say we've treated with steroids, and the follow-up imaging can be done with a low-dose CT and non-contrast to follow up abnormalities. If there is a question about the diagnosis, a high-resolution CT scan, again, contrast is not needed, may be more helpful for diagnostic purposes. Why? Because you get thinner slices. You can do it with expiratory imaging, prone imaging, so that we can eliminate that concern about compressive atelectasis. So it has its role, high-res CT, doing tests with contrast, of course, if we're trying to rule out pulmonary embolism, has its role, but not every imaging follow-up needs to be either with contrast or high resolution. And why is this important? We have to consider that we're exposing these patients to repeated scans very, very frequently. Our cancer patients are living a much longer time. And so the dose of radiation exposure is really not negligible. A low-dose CT will emit about a quarter of what a regular CT scan emits in terms of radiation exposure. Our background exposure is about 3 to 4 millisieverts in a year. But if we think of a CT chest abdo-pelvis, one scan is about 15. It's about 5 times the annual exposure for a patient in the one scan. So it's just certain things to keep in mind and to try to make sort of clear choices about what test we need and why we need it. So now I'll delve into a little bit of the radiology and what we're looking for and what diagnoses we can make based on the radiologic imaging. So the main patterns of drug-induced interstitial lung disease include ground glass opacities, organizing pneumonia, a nonspecific interstitial pneumonia pattern, and diffuse alveolar damage. And this is the one that clinically patients will present with acute interstitial pneumonia, very ill and oxygen dependent. So this is what an organizing pneumonia would look like, sort of a dense, consolidative area. There's sort of peripheral ground glass around it. You might see a reverse halo sign there as well. It's usually a larger volume. There may be air bronchograms in it as well. Can actually look like a typical pneumonia, right? So someone who comes into the emergency room because they're coughing and they have a bit of mucus, may CT scan like this looked at by the emergentologist may be diagnosed as community-acquired pneumonia, and off they go with antibiotics, not necessarily recognizing that they're on a therapy that could predispose to a pneumonitis, a drug-induced toxicity. And these patients sometimes can even worsen on antibiotics, of course, because we're not treating the underlying cause, and come back with an even higher grade illness. So very important to educate not only our patients to inform that they're on these drugs, but the healthcare professionals around them who might see them. Here's a pattern of nonspecific interstitial pneumonitis. So this has a more sort of peripheral, reticular changes, maybe more basal, sparing. There's a bit of a rim where it spares the immediate subpleural area. So a pattern that we recognize radiologically as NSIP. Here's a pattern of what radiologists would call hypersensitivity pneumonitis, an HP pattern with some mosaic attenuation, some centrilobular nodules, a little bit of ground glass, absence of, sort of scarring, honeycombing, and things that we typically see with fibrotic changes. And here's an example of a diffuse alveolar damage where there's more widespread ground glass. These are the types of pictures that you see when patients present with ARDS in an ICU setting. Now, I've talked about what the typical patterns are, but I will say that I get a lot of referrals for patients who are on either immunotherapies or TKIs or ADCs who have a written radiology report with new findings, new nodules, new ground glass, and not all of these things are drug-induced. And some are very, very subtle. So which ones do we take seriously? So I put one example here of a metastatic breast cancer patient who was on a TDXD, so trastuzumab deruxtecan, and had received 14 cycles. She developed on this staging CT, or just a restaging CT, the one on the far left, new peribronchovascular ground glass nodules. So that word, that phrase shows up in the report, right? Because the radiologist is comparing to the middle frame there, and it was not present previously. The radiologist also commented on some other findings that are paraspinal. So there's paraspinal reticulations, and there was some subpleural changes. So the patient was referred to say, well, is this pneumonitis or not? And do we hold the drug or not? And in looking at previous imaging, I can see that the subpleural changes and the ones that are paraspinal actually were pre-existent. And this was in a previously radiated field. I could go back to the radiation oncology notes and see that the patient had been treated in those areas. And that didn't worry me at all. The example that I circled at the bottom of the right lung was, in fact, a peribronchovascular nodule. I didn't have enough cuts to put in other slides, but there were others scattered throughout with some central lucencies, with maybe a little bit of air bronchogram through them. And as subtle as they were, I actually did consider that this was probably an early sign of pneumonitis. And with this particular drug, and I'll explain in other slides, it is pertinent to hold and then reassess. And I will say that this patient had another particular risk factor, is that the frame on the far right was when she had been treated with everolimus. And everolimus is one of the drugs that can also give a pneumonitis. And on that scan, I don't know if it projects well, but there's some diffuse ground glass opacities. So there's a pre-existing pneumonitis that had happened. And this, again, predisposed her with another drug, putting her at risk. And that raised my index of suspicion. So that could have been missed had it not been reported by the radiologist and highlighted by the medical oncologist. So the most common causes of drug-induced ILD are anti-cancer agents, in fact, and we're using so many more of them in many classes. So you'll see here just a non-exhaustive list, but any grade ILD sort of runs somewhere in the range of, 1% to 5% for the most part. When we're looking at small molecule TKI, EGFR inhibitors, when it comes to immune checkpoint inhibitors, you're probably in the range closer to 4 to 6% with some of the immunotherapy agents. But down here, I'll highlight at the bottom the trastuzumab deruxtecan. So this is one of the ADCs that I'll talk about, where the incidence of pneumonitis is actually quite a bit higher. And I'll review some of the data or the literature showing that, but as high as 15% in the breast cancer literature. And delving a little deeper into the TKI therapies, so these are some of the drugs that I use, certainly the EGFR inhibitors and the ALK inhibitors for my lung cancer patients. Osimertinib is a drug of particular interest, so an incidence of a pneumonitis that's at around 4% and higher than the earlier generation TKIs. And even more importantly is that the risk of pneumonitis is even higher if the patient's been exposed to immunotherapy first and then goes on to the TKI after immunotherapy, especially if it's within the first 3 months of exposure. And so we pay particular attention to knowing their molecular status ahead of making a decision about treatment, because we want to know for sure a patient is EGFR negative before giving them immunotherapy and not switching. For ALK inhibitors, particular attention with brigatinib. So brigatinib is a TKI that works effectively, CNS penetrant, very active drug for ALK-positive lung cancers, but a rate of pneumonitis that's higher than 5%, but here I quoted about 4 to 9%, very rapid onset. It's with initiation of the drug, so much so that we now sort of step up the therapy with a half dose for 1 week, monitor, and then up the dose to full dose the second week. And I listed a few others here with an incidence of anywhere between maybe 2 to 5%, but something like everolimus has a higher incidence, somewhere in the range of 10 to 15%. If we're looking at immunotherapy trials, so across all tumor sites or across all different types of molecules, we're kind of sitting in that 4 to 6% range. It's a little higher when immunotherapy is combined with a CTLA-4 inhibitor. And we do see that in non-small cell lung cancer, it's a little higher than other tumor sites, same with renal cell cancer. And now the sort of newer class of monoclonal antibodies and ADCs, where we see specifically in the breast cancer world, the TDM1, Dato-DXd, TDXd, where the incidence of pneumonitis with Dato-DXd is around 5% from a pooled analysis, but even higher with TDXd. So this is a drug of particular interest for respirologists because we're seeing a lot more referrals, and we'll get into the importance of it and the management of it on the next slides. So this is a summary of the incidence of ILD from the Destiny Breast trials, where we see that the incidence of ILDs were any grade in the range of about 10 to 15%. In the gastric studies, also sitting at around 10%. But in the Destiny lung trials, much higher rate of ILD. So even in 1 out of 4 patients would develop an ILD. Of note, in the breast cancer trials, the patients are selected based on their HER2 immunohistochemistry staining, so HER2 positive 3+, 2+, and so on and so forth. In the Destiny lung trials, these are ERBB2 mutated patients that were selected for these trials. So a bit of a different patient population, but an incidence of pneumonitis, which is quite a bit higher. And remember that lung cancer patients, of course, have the highest burden of disease in the lungs. So the target is there, and that's where we're drawing the drug. From the Destiny Breast 3 trial, you see that compared to TDM1, which is a drug that medical oncologists were used to giving in breast cancer, the incidence was much, much higher. So this was a signal that was really quite worrisome. And there were some grade 4 and 5 events, not from this trial, but earlier trials that had been reported. And finally, I meant to suppress this one, it's still there, but it's basically just a summary slide looking at the overall risk of pneumonitis. Okay, so when does the pneumonitis happen? So if we look at the data for the ADCs, and certainly with TDXD, it's going to happen within the first year of therapy. So we're most vigilant sort of in that startup and in the first few months up until sort of the first year of treatment. It kind of levels off in terms of the rate of occurrence. When it comes to immunotherapy, so again, it can be variable, it might be idiosyncratic, can happen at any time, but we do see that it's also within those first 36 weeks or so. Earlier on in the, up to about 40 weeks, that we see the peaks for all of the immunotherapy drugs. Okay, so what are the mechanisms of injury? So understanding the mechanism of injury also helps us with our treatment approach and our management. So the mechanisms are not fully understood. We have certainly knowledge that baseline interstitial lung disease and parenchymal disease puts patients at more risk. For the EGFR TKIs, molecule like osimertinib, we know that there's EGFR that's expressed on the type 2 pneumocytes. And that's involved in alveolar repair. So of course, if we have an inhibitory mechanism, then that can potentiate lung injury and impair repair, of course. With immunotherapy and ADCs, I'll show them on the next couple of slides. We've seen some of these mechanisms. We looked at it with the colitis. This is sort of a pictogram with what happens in the lung, but there's felt to be upregulation of Th1 and Th17 cells, excessive cytokine secretion, causing damage to the cells. And we see downregulation of the Th2 cells and T regulatory cells, leading to the absence of the immunosuppressive control. And of course, all of this pro-inflammatory secretion that causes cellular damage. The mechanism for ADCs is entirely different. So this comes from the design of the molecule. I think this pictogram was shown in another talk earlier, where we see that there's an anti-HER2 antibody, and then there's a linker with the what we call the payload. The payload is the actual drug delivery, the chemotherapeutic agent that's being delivered into the cell. So in the case of TDXD, this is, in fact, a topoisomerase 1 inhibitor. So the trastuzumab is linked with the deruxtecan. And there's binding at the surface of the cell, internalization into the cell, so meant to be more specific. Once it's in the cell, the cleavage happens so that the payload is released and the cytotoxic effect happens within the cell, okay? Of course, no design is perfect, and so you may have some leakage of the drug towards neighboring cells. This is what we refer to as a bystander effect. And some other causes here that I listed may relate to premature cleavage. So it's outside the cell, and some of that drug may be released outside the cell, causing damage. It may be because of the payload diffusing across membranes to other cells. And it may be just because of mutual receptors that are found, and the drug's kind of mixed up and goes on healthy cells and not just cancer cells. So a variety of possibilities. We'll get to the principles of management. So here, the most important message is that there has to be heightened awareness. Okay, so we're used to telling our patients to be, cognizant of any changes or symptoms from a respiratory standpoint if they're on immunotherapies, if they're on TKIs, looking for rashes, looking for other side effects. When it comes to the ADCs, and we'll get to it in the management, because there is an importance to early detection before patients have symptoms, because once they've developed symptoms in higher grade pneumonitis, there's actually literature and guidelines that tell us that the drug has to be stopped, and it deprives patients potentially of important therapies. So the early detection is important. I made a note here to alert the radiologist on your requisitions. So radiologists may not be looking for pneumonitis. They may just be looking for tumor response and assessing size, improvement in the target lesions. So by alerting the radiologist that you're looking for pneumonitis, they'll report subtle findings that may not have been previously detected on earlier scans. There's a differential diagnosis to keep in mind, as I mentioned before, and early referral to respirology just to kind of get that clinical radiographic correlation, I feel is important as well. We talked with earlier speakers about the importance of sort of this multidisciplinary collaboration and using the expertise around you to try to make informed decisions. General rule of thumb, when in doubt, hold the drug until we're able to evaluate and sort of go with safety first. And I do believe that the multidisciplinary approach and even the use of more specific tumor boards. So I have the privilege at our institution of having an immuno-oncology tumor board where we discuss difficult, challenging cases, when to make a decision to hold, restart, treat, how do we treat? So these types of discussions and learning from each other, I think, is very important. And knowing that this, novel classes of medications also require very specialized approaches is important to do in that type of setting. So here's a review article. Actually, lead author was Dr. Asala. That's our moderator here today. So it was Managing Risks of Lung Toxicities with Trastuzumab Deruxtecan. And it's written with a Canadian perspective in mind. And I liked it because it really shows this multidisciplinary approach. So we need to have the involvement of the medical oncologist, the radiologist who's aware, knows what they're looking for, knows what to report, knows to look at previous imaging and detect if there are new findings. And the respirologist with an expertise in that clinical radiographic correlation, evaluating for differential diagnoses, using PFTs, bronchoscopies if necessary. So what do I do in my workup? So take a good history, looking at the chest imaging, deciding whether it's pertinent to do respiratory function tests or PFTs at the time of assessment. Certainly at baseline, it's important to have some of these patients with pre-existing risk factors do PFTs, and deciding on the role of bronchoscopy. Some of the other things that we might do are blood tests, blood cultures, ruling in or ruling out infectious causes, and some other sort of inflammatory markers that we can detect on blood work. So a word about PFTs, because I often will get referrals that we're worried about a pneumonitis and the patient needs an urgent PFT. So PFTs may not actually impact on decision-making in the moment, right? So I think it's important that a patient who has prior comorbidities, prior history of interstitial lung disease, that we have a baseline. We need to know their diffusing capacity, need to know their resting oxygen saturation, even need to know if they desaturate at all when they walk. It's an easy test in the clinic. Just have them walk around the clinic for a minute and then check their oxygenation. But PFTs are difficult to get. I think the climate, certainly in our institution, in our province, maybe across the country, is that with manpower shortages and resource limitations, it's very hard to get PFTs very quickly. There's actually no data to support that there's a reduction in drug-induced ILD incidence by monitoring PFTs. Okay, so it might be a way to monitor the side effects or the complications later, or the degree of impairment after the fact, but it certainly is not a preventative strategy. And so this is something that we might use to inform us of the pertinence of rechallenge or risk with rechallenge. For bronchoscopy, so this is similar to the discussion that was had about colonoscopies earlier with the colitis talk. Certainly it's helpful to us for a workup of infection to rule out infectious causes. If there's a suspicion, perhaps, that there's progression of disease and we need a biopsy to show that it's actually progression of disease rather than a drug-induced lung alteration. So it's important, but there's no pathognomonic histopathologic feature that's going to clinch a diagnosis of drug-induced lung injury. Okay, so it's not necessarily going to change our management if we are clinically suspicious enough about a drug-induced lung injury. So most of the time, it's our clinical suspicion, history, radiographic findings, and we would initiate therapy if we feel that the patient fits that diagnosis. If we do biopsy, so when I have done transbronchial biopsies, and most literature shows that it's a lymphocytic infiltration that we end up seeing on tissue, sometimes eosinophilic, common to drug toxicities in general. You may find granulomas, septal thickening. These are some of the chronic changes with lung injury in general. Again, non-specific. So because there's a lack of a diagnostic pattern, it means that the lung biopsy is rarely justified unless we're ruling out another diagnosis, okay? And that the bronchoscopy will rarely help clarify a diagnosis with a grade 1. So someone who's asymptomatic with very subtle radiographic changes, bronchoscopy will not change my diagnosis or my management or clinch a diagnosis. With grade 2, so once patients become more symptomatic, you have an opportunity to intervene with bronchoscopy. We have to be able to get them to the bronch suite quickly enough and have space and a spot for them. But if they're even higher grade or they start to decline quickly, once they need more oxygen requirements, it becomes a little more tricky to do that procedure, becomes more risky to get transbronchial biopsies, risk of a pneumothorax and clinical deterioration. So never would we not initiate therapy with steroids, for instance, waiting for a bronchoscopy to happen. With TDXD, so particular message about this is that, again, it's very important to sort of screen these patients ahead of time for risk factors for ILD. Typically, these patients get screened, I guess, in the medical oncology clinics every 9 to 12 weeks or so, every 3 months or 4 months, and they have routine restaging scans. And if it's suspected on one of the scans that there's a grade 1 pneumonitis, we need to hold the therapy as of grade 1. So I get to that, I think, on the treatment slides. We'll get to that next. So to review the grading system, so similar to what we've seen with other toxicities, grade 1, asymptomatic, you only have radiographic findings. Grade 2, patient starts to have some symptoms. It might be a mild cough, maybe some dyspnea on exertion, and their IADLs may start to be limited. With grade 3, these are typically the patients who are presenting to the emergency department. They may be requiring some oxygen. They have symptoms that are more marked. And grade 4, life-threatening. Grade 5, unfortunately, they may present with a mortality. So in general, when it's a pneumonitis that I suspect from a TKI, our goal is to hold drug. So if there's a suspicion, hold drug. exclude other causes with the differential diagnosis that we reviewed just a few minutes ago. Initiate steroid treatment as a general rule when there's signs of pneumonitis from TKI. I'll go with 1 milligram per kilogram. This is what's been reported in literature for a lot of these TKIs. Monitor the response clinically and radiographically. And normally it requires a fairly tight monitoring, meaning we're watching these patients within 48, 72 hours. Pneumonitis from drug toxicity is very steroid responsive. Patients feel better and your vital signs improve and radiography improves relatively quickly. And if it doesn't, we tend to escalate the steroid treatment. In general, it's recommended if there's at least a grade 2 or higher, and I think grade 2 we're a little more lenient, but grade 3 or higher toxicity, that we discontinue the TKI. Certainly, this is something that is kind of taken into consideration when we look at cancer response to targeted therapies. For some of these patients, there may be lack of an alternative treatment, the grade of severity, the resolution, how quickly they resolved, and how steroid responsive they were. So these are some of the things that we would discuss at a tumor board as a case by case, about rechallenge, that is. Now with immunotherapy, the guidelines guidelines like this have been out for a long time when it comes to treatment of pneumonitis. For grade 1 with immunotherapy toxicity, we typically will say they're asymptomatic minor changes. We can either hold, kind of wait a cycle and reimage and resume if it's improved and if they're still asymptomatic. Some may choose to give a low dose of cortisone, reimage, and rechallenge. But these patients are monitored and they can resume therapy. With grade 2, we will typically have to hold the therapy, initiate oral steroids, watch them closely, follow up imaging, and we can rechallenge after a grade 2 toxicity as well. If there's worsening or deterioration after initiation of oral steroids, we'll escalate and treat them as if they were a grade 3. With grade 3, of course, these are more sick patients hospitalized on oxygen requiring IV steroids, close monitoring, and escalation of their immunosuppression if they're not responding to intravenous steroids. And here you'll see, and I have it on another slide, but this is where we also will consider using drugs like infliximab, might add IVIG. I have given tocilizumab in cases like this as well, where they were steroid refractory. So here's an outline or a summary, I guess, for the more severe pneumonitis. So when we see that they're beyond grade 2 or requiring higher doses of IV steroids and not improving, they will receive infliximab, usually 5 milligram per kilo for the first dose. Repeat the dose in 2 weeks if they're still steroid refractory. Might add IVIG, may consider tocilizumab, and so on and so forth. Okay, these patients tend to be quite ill in hospital. For refractory pneumonitis, or the ones that we have trouble getting off steroids or tapering off steroids, we may consider MMF in these patients as well. So in summary then, if you look at this chart, and I'm going to make the distinction between immunotherapy management of pneumonitis versus ADC management with T-DXd, here with a grade 1, you can continue the immunotherapy if they're asymptomatic, and only if they worsen or their imaging worsens, you would consider stopping it at the next cycle. Others may be more reluctant and you can hold and resume with the following cycle. But typically with grade 1s, optional as to whether to treat or not, monitor, and you can go ahead. With grade 2, we will stop therapy. You will start steroids, reassess, and as long as it's recovered to a grade 1 or less, you resume your immunotherapy. We typically would stop at a grade 3 and of course with a grade 4. The rechallenge, as I mentioned, as long as they're back down to a grade 1 or less, or on 10 milligrams of prednisone or less, we would rechallenge with immunotherapy. The recurrence rate, I think it was mentioned on one of the previous talks as well, it can be quite high. So at least a quarter in my experience, but it's quoted about 30 to 50% will have another immune-related adverse event, pneumonitis plus minus something else when we rechallenge after a first incidence of pneumonitis. What factors go into deciding about a rechallenge? So when I'm assessing a patient who's had a pneumonitis, certainly the degree of severity, so the grade 3 or more, I tend to shy away, of course, especially if they've had fibrotic changes or some chronic scarring. Grade 2 or less, I have no problem rechallenging. Their response to steroids, if it's been very rapid, very steroid responsive versus slow to improve, it took a long time to wean, or we needed to escalate to other immunosuppressive treatments. Certainly, if they're on 10 milligrams or more of prednisone to maintain control or symptom management, I would not. And this is where I would look at PFTs to see if they have that physiologic reserve. Did their DLCO drop from pre-treatment to post-treatment? Are there fibrotic changes that we see on their imaging? Tumor response is important. We've alluded to this in other talks as well. Sometimes these patients who have immune-related adverse events have very significant clinical responses. And once they're in remission or partial remission at least, there's really no urgency to retreat, certainly if they had a significant toxicity. So normally my approach would be to just watch and wait and let the tumor force my arm. So if at one point it starts to grow again, I might re-challenge them at that point with the knowledge that we'd have to have closer surveillance because of an event that happened prior. And the importance of evaluating whether we're in a curative setting versus a palliative setting. I have a couple of examples. Essentially, a patient receiving pembrolizumab for a metastatic renal cell cancer who developed an organizing pneumonia, so a very severe grade 3 pneumonitis, was tapered off prednisone after a few months, went back to a grade 1 because there's still ground glass opacities around it. And this patient was not rechallenged given the severity of his presentation, but off prednisone had a recurrent event. So tapered off, recurred, and had to be treated with infliximab and tocilizumab with recovery. And he actually stayed in remission, not requiring any systemic treatment for well over a year. This is a patient of mine with an adenosquamous non-small cell who had a T4N0 tumor, had neoadjuvant chemoimmunotherapy, great response. So the two images on the left side are at the start of treatment, on the right side post 2 cycles. And you can see that there's now a cavitary lesion, so response, the tumor actually cavitated, but then you have all these ground glass opacities that showed up elsewhere. Surgeons always get nervous preoperatively if there are new findings because you don't want the patient to progress and then you take them to surgery. But the patient had a very short course of prednisone follow-up imaging, resolution of those ground glass opacities, and went to surgery, and she had a pathologic complete remission. So now quick word just about the management for the TDXD, as opposed to what I showed you with immunotherapy. Here, if a patient has a grade 1, so pneumonitis, meaning just picked up on screening CTs, then the patient would have to have the therapy held, okay? So we don't want it to go untreated or unnoticed because at grade 2, the indication is to permanently discontinue therapy. So this is an important difference between the ADC versus immunotherapy. And this is the case for TDXD and also with Dato-DXd. So if the pneumonitis resolves within 28 days, you can re-challenge and the patient can be retreated. If it takes longer than 28 days, there should be a dose reduction at least of 1 level below. And if it takes a long time for this grade 1 toxicity to resolve radiographically, because of course they have no symptoms, the drug should still be discontinued. Grade 3 patients are presenting, of course, more ill in hospital. It requires prompt treatment with high-dose steroids. And of course, there would be no re-challenge if they presented with a grade 3 or 4. This is just to highlight that with Dato-DXd, where we also have a little bit higher incidence of pneumonitis as opposed to the TDM1 groups, similar guidelines that have been written up. So for grade 1s, really, we must be vigilant, monitoring the radiology and intervening quickly. This one quick slide on re-challenge for TDXD. So we see that these patients can be re-challenged safely after a grade 1 toxicity. And again, with close surveillance, the ILD pneumonitis duration was very short. They were re-challenged and the patients could continue on therapy until progression. And this is an example from a pooled analysis where these patients were safely retreated. 33% of patients were retreated for greater than 6 months, so they could be rechallenged and safely treated, and at least almost 20% for a full year. A note about dose reduction. So typically with the first pneumonitis, it may be a good idea to dose reduce right away if you don't want to rechallenge at the same dose, and monitor the patient on the lower dose as well. Finally, my last couple of slides. So the roles of the multidisciplinary team. So again, I'm going to highlight that it really involves the cooperation between the medical oncologist who knows the patient and their treatments, advising the radiologist, involving your respirologist for investigations, reviewing radiology and monitoring them while on therapy with steroids, and information by the healthcare professional. And just a final note about the art of the clinical and radiographic correlation. So the real world experience is such that as we gain more experience, as we become more comfortable treating these patients, I think that not all grade 1s are reported by radiologists, so we have to be cognizant of that. I think not all symptoms are related to the subtle radiographic findings. You might have a tiny little finding with a cough, and the cough is postnasal drip or GERD, so they're not all grade 2s. And not all grade 2s have the worst risk or outcomes, right? So I think we kind of have like a grade 2A, grade 2B population that we have to tease out, and we need more predictive data to manage that. So this is just a summary slide. So pneumonitis is an important toxicity, a risk of morbidity and mortality. Heightened awareness and surveillance is paramount. Most cases can really be detected, can be managed effectively if detected early and early intervention. And there are differences in the management with whether it's a TKI, immunotherapy versus ADC, drug toxicity to the lungs. And we want to follow these guidelines so patients can maximally benefit from therapies. So I'll stop there, and I don't know if there are any questions now or later. In the chat group.
Yes. Hello, Dr. Pepe. Thank you very much. We have, and I think you know, a challenging case at the SHUM of HER2 non-small cell lung cancer, and had repeat pneumonitis on the slightly lower dose of TDXD. Now she recovered the scan just 1 hour ago.
Okay.
Should we restart with a bit of prednisone or decrease the dose again one more time?
Okay, so the microphone, I think, is s'affiche un peu. So the question, so the patient is on a trial with TDXD, had a grade 1 pneumonitis.
Grade pneumonitis.
Grade 2 pneumonitis.
Was treated with prednisone, improved, re-challenged with the drug, had another grade 2 pneumonitis.
Sorry, the re-challenge with the grade 2 was at the same dose?
Yes.
Okay.
And then prednisone,
and now the question is whether to re-challenge a second time.
With prednisone or not?
Right.
No re-challenge.
Okay, so this is uncharted territory, and it's a little off script because, again, the guidelines clearly do say grade 1 re-challenge. In fact, grade 1 greater than 28 days to re-challenge with a dose reduction. If it's grade 1 within 28 days, you can challenge at the same dose. I personally think that we're going to head towards grade 2s that are mild, that are very steroid responsive. I would feel comfortable with a patient who has normal baseline lung function, whose radiology recovers, who has good physiologic reserve, to re-challenge a grade 2. That's where my idea about the 2As and the 2Bs come from. However, in this case, you have a patient who's was re-challenged and had a recurrent pneumonitis, and you have a drug where I think that the risk of a higher grade and more permanent toxicity is higher. 100%, I would reduce the dose. I would not re-challenge at the same dose. Reduce the dose with a 10 milligram of prednisone on board, maybe. Kind of depends what your protocol allows you to do. It's a little off script, but yeah, I'd have to sort of evaluate all the physiologic parameters.
Yeah, time for one last question.
I can hear you. I'll repeat the question, sure.
So, technology of the checkpoint inhibitor induced pneumonitis and the prevalence in the, I guess, in the bronchial fluid of TH17.
Yep.
So I think that's been described in other toxicities, right? The TH17 seems to be a big cell involved with toxicity. And I think our IL-17 inhibitors have an impact on TH17 cells. And the question is, I mean, you're using infliximab, tocilizumab, phenolate, like what we do with idiopathic pneumonitis, like I talked about.
Yep.
But has anybody looked at a TH17 inhibitor or IL-17 inhibitor for specifically pneumonitis? Because I wonder if that could be a better target.
Right. So the question relates to the pathophysiology with the role of Th17 and in pneumonitis, typically what we've been using in our guidelines really is what we've always been doing. So you're right. And we mentioned this on previous talks. We kind of are used to giving immunosuppressive therapy, which includes steroids and infliximab and tocilizumab and these types of agents and MMF. So the question then is, would it be more pertinent to use something targeted like an anti-Th17? And I think that that's where the bench research has to go. I'm not a basic scientist, but I do think that that's where it's headed. In my practice and in pulmonary medicine, a lot of the monoclonal antibodies that we see that target asthma and all the inflammatory pathways have all been developed in that respect. And I think that we need to collaborate with the sort of the bench research that happens in an interstitial lung disease. So primary ILDs, the UIP patients, these patients have pathophysiology that brings them to develop lung cancers, right? These patients have interstitial disease that predisposes them to pneumonitis when they're exposed to these types of drugs. So I think at the cellular level, we do have to look at those mechanisms and then really generate more specific data. I entirely agree, but I don't think we have anything like that right now. No, not that I'm aware of. Yeah, I agree. Okay, thank you so much.